So I want to start it with a little thing from the Irish Mental Health Hotline.
Hello and welcome to the Mental Health Hotline. If you are obsessive compulsive, press 1 repeatedly. If you are codependent, ask someone to press 2 for you. If you have multiple personalities, press 3, 4, 5, and 6. If you are paranoid, we know what you are and what you want. Stay on the line and we'll trace your call. If you're delusional, press 7 and your call will be transferred to the mothership. If you are schizophrenic, listen carefully and a small voice will tell you which number to press. If you're depressive, it doesn't matter which number you press, no one will answer you. If you're dyslexic, press 69696969. If you have a nervous disorder, please fidget with the hash key until the beep. After the beep, please wait for the beep. If you have a short-term memory loss, please try your call again later. And if you have low self-esteem, hang off. All our operators are too busy.
That is the Mental Health Hotline. So I start this thing on personality disorders, and really, personality disorders are, we save it for the end because some of the concepts are a little difficult for you guys to kind of hang on to. So I'm going to be talking about those differences and what we're going to do for them, and I think I've got a technique or two that's going to help you remember. All right, remember that the difference between the DSM-4 and the DSM-5, there's none of the criteria for personality disorders has changed in the DSM-5, so that's kind of good for all of us because we've been kind of doing both. So we'll move on to terms here, and that is terms. Personality. Personality is an ingrained, enduring pattern of behavior. That means it is a behavior lifelong. We can change it, but it takes time to change it. It's not something that changes immediately. Personality disorders are diagnosed when personality traits, and every one of you has traits, become rigid, inflexible, exaggerated, maladaptive, and begin to significantly interfere with your daily life or the life of others, as the case may be. Personality disorders do overlap at times. They can coexist with other mental illness, but just remember that lifelong pattern of behavior. That's really what we're looking at here. So you don't get a personality disorder overnight, typically, unless you had a brain injury. That does occur sometimes. All right. So the defining features, per the DSM-5, which we're going to use for these purposes, there's 4 core features: distorted thinking patterns, problematic emotional responses, over or under regulated impulse control, and interpersonal difficulties. Now, in addition to these 4 core features, the 10 personality disorders can be divided into clusters, and those clusters are based upon the similarities of each of the personalities within them, such as, and by the way, we use the term cluster to group together disorders with similar behaviors or symptoms. So we've got odd and eccentric. So we've got paranoid, we've got schizoid, we've got schizotypal. Those are all odd folks when you see them. When you see dramatic and emotional, or erratic, antisocial, borderline, we're going to get more into borderline later, histrionic, one of my favorites, narcissistic, all of those are very dramatic. Anxious or fearful, avoidant personality, you know, you've got to worry about somebody running away. Dependent personality, which can be very annoying. And obsessive compulsive, these folks, unfortunately, nursing has as one of its traits, and every nurse I've ever known, we're slightly all a little OCD. Because we're the ones that go back and check that IV for the 100th time just to make sure it hasn't infiltrated, and that's why we find them and save the patient from having difficulty with their arms. All right, other related or future types, these are actually being proposed and they've gone back and forth. Those are the depressive personality disorder and passive aggressive personality disorder or traits, as the case may be. So in the DSM personality categories, cluster A, as I said, persons who have behaviors that seem odd or eccentric. Cluster B, people that are dramatic. And cluster C, those that are anxious or fearful. And please note that borderline and antisocial are very prevalent in society, I'm sorry to say. We'll talk about why when we get to talk about the individual disorders. Safety. As your text often states, I'm going to say this over and over again, safety, safety, safety. This is the big problem with these disorders, is a lot of times they will put both themselves and others at risk. What's the criteria to be involuntarily placed in a hospital? A danger to
Themselves or others.
yourselves or others, that's correct. So that's the point, is that safety is going to be your big issue with them. These have a higher incidence of suicide, suicide attempts, self-harm, accidents, and you'll see that in ER visits. They also have a much higher rate of alcoholism and drug abuse, typically because they are trying to self-medicate along the way. They also have some criminal behavior, which we're going to discuss, that need either the general population or other mental health, more so than the general population or even the other mental health disorders have. So they often will try to make a game of suicidal gestures and will time the staff, how long it took to rescue them, which is a very bad game. And so I'm going to tell you the story of how that happens. We had a gentleman that was a borderline, and it's unusual to have males as borderlines, but he was, and he was timing the ambulance. He would take his overdose, call the ambulance, and say, okay, they'll be here in 15 minutes, they'll save me. We went through this multiple times, and so we had a meeting with him and the family and everyone and said, look, one of these days that ambulance is going to be on a different call, and they're not going to get there in the time that you think. And it's going to be a different ambulance, and they're going to be 10 minutes late. And you're going to be 10 minutes dead. And 6 months later, our comments came true. The gentleman understood what the danger was, we understood it, but there was not much we could do at that moment when he thought to do it. Does that make sense? We had done everything we could, and we'll talk more about what you do with the borderline and how you help them prevent that. These disorders occur very commonly. About 10 to 20% of the population has one or more of these diagnoses, with lower socioeconomic groups showing an even higher incidence, which isn't surprising because their coping skills are lower. When the question being, do these disorders make it harder for people to succeed, thus earning less, or does earning less push these people into poorer coping strategies? Well, that's a good question. I don't know the answer to it. Probably, to some extent, both are true. Patients with these disorders are considered treatment resistant per the text, and we're going to talk about why that is as we go along. These are lifelong patterns of behavior because they're not due typically to chemical changes like schizophrenia might be. They don't respond well for the most part with medications, and that's one of the real big issues here. Some of these disorders tend to diminish beginning in the 40s and 50s. An example would be like borderline tends to get less, and antisocial also, but others such as schizoid and obsessive compulsive do not diminish. And that diminishing trend is sometimes called the term burnout. It simply means that the symptoms are no longer manifesting themselves. We know that you can have two patients that have the same parents, same experience, yet respond very, very differently, with one patient developing a personality disorder and the other showing themselves no worse for the wear, so to speak. So we've got these traits here that I keep talking about. And in the biologic theory, it says, well, we have temperament traits, and these are ingrained by the age of 2 to 3. And we've got genetics that account for about 50% of our trait variances. These traits are largely inherited. But again, as I said, you've got two people in the same household. One of them develops this personality disorder, the other one doesn't. Big things they look for with our personality thing is harm avoidance, novelty seeking, reward dependence, and persistence. And those are pieces in there. Certain disorders often develop in families. They tend to be what's known as familial. Schizotypal is common in families with schizophrenia. We have noted that as a trend. Obsessive compulsive, borderline, and antisocial are strongly familially linked, genetically linked. And we've also noted lower serotonin neurotransmitters that's linked with antisocial and borderline. And what that's doing in the brain, we're not really sure. We just know that that does occur. So we've got the psychodynamic theories. We've got learning accounts for what we term personality traits. Again, those three character traits are self-directedness, cooperativeness, Self-transcendence, I love that one. It sounds like some kind of thing in the 60s. Hey, well, we're going to go do the self-transcendence, you know. Childhood trauma becomes one of the big risk factors here for a lot of these personality disorders, borderline specifically, as we will see as we go along, particularly damaging and also antisocial. All right, cultural considerations. We live in this vast multicultural world, so it behooves the nurse to constantly be aware of or observing for where these different cultures lend themselves to misinterpretation by health professionals, if that happens, leading to a misdiagnosis or perhaps an inappropriate diagnosis. So we've got judgments. You know, is this person a member of a minority? Do we have conscious or unconscious thoughts about that make us tend to diagnose them more because they're a minority? Are they a political refugee? Do we have feelings about that lends us to have that bias? Are they a recent immigrant? You know, did they just come over the border about 10 minutes ago? Do we have thoughts about that? Do they speak a different language, which sometimes puts a bias on us as well? Different religion. Gender bias. We've got lots of gender bias. Antisocial and schizoid are diagnosed more in males, and borderline and histrionic tend to be in more females, and this we sometimes think, is that our clinical bias? Because we know it's like, are they really that prevalent in the male and the female, or is it our bias that does it? Treatments. Please note that while there are no, now this is important, there are no current specific medications that are effective for a specific personality disorder. However, patients do have symptoms that respond to some of our current medications. It should be noted that the latest trend for treating borderline has shown that the efficacy of cognitive behavioral therapy for long periods. One study showed that a year or more of cognitive behavioral therapy, about 50% of the patients no longer met the criteria for borderline disorder. So is CBT effective? Well, a year later, half your patients are no longer showing the symptoms. That's pretty effective. There is a prejudice against therapy as far as third-party payers goes. They tend to be pro-medication, you know, give them a pill, get them out of your office, as opposed to let's talk about it. And that's one of the big issues that you guys are going to face, is promoting folks to go to therapy. Because therapy solves a lot of these issues way better than a pill. The pill is going to get some of the symptoms, but it's really not going to stop the underlying personality issues. Okay, please also note that the aggressive diagnoses respond to the mood stabilizers like lithium and antipsychotics. The mood and anxiety disorders seem to respond to the SSRIs, sometimes to carbamazepine, which is a mood stabilizer, and some of the antipsychotics, but none of the meds work specifically for any of the disorders. So, if you've got an aggressive patient or impulsive patient, these are some of the things that we have used to address those issues. So aggression, lithium, anticonvulsants or stabilizers. This is the carbamazepine, the Depakote, those kind of things. Tricyclic antidepressants. And the problem with tricyclics is, in an overdose, what happens to you? Heart block. So, you know, you're handing them the drug that's going to kill themselves. And if you give this to an aggressive person that, say, is borderline and wants to be suicidal all the time, probably not a good mix. Benzodiazepines, and I'm always going to put an asterisk next to benzos because this is a lifelong pattern of behavior, and we're giving them a short-term drug. Is that a good mix? No. We can use it as a PRN, and we do have the occasional person that you can give it to for a little bit longer than that, but for the most part, benzos are probably not a good choice for these folks, except in a PRN situation. All right, mood, again, lithium works well for that. Anticonvulsants, again, work well for that. And now we get into the SSRIs and the SNRIs. Things like Prozac, Zoloft, etc. Those are the drugs that we're going to be using. These are all the newer drugs. They work really, really well, and they're getting the mood symptoms to stabilize. That's the big deal here. So for all intents and purposes, that's what we're trying to do. Antipsychotics, mostly the atypicals. Why the atypicals? Why do they work? go back and think about what the antipsychotics do. Normally they work on dopamine, which works on the type 1 symptoms, the positive symptoms. But type 2 are basically under serotonin and norepinephrine. These drugs, the atypicals, also work on serotonin and norepinephrine. So the antipsychotics are often used for their mood stabilization properties. Does that make sense? So yes, that would also be a good choice. So if you chose Thorazine on a test question to give to somebody that has a mood disorder, it's probably wrong. But if you gave Zyprexa, that worked. All right, anxiety. Number one thing, as I said in my anxiety lecture, was SSRIs or SNRIs, as the case may be. And those are really the thing that we're using today because you can give them lifelong. You can give them over long periods. You're not worried about abuse potential with those. They're much, much safer. We again can use the tricyclics, and you have to select your patient very carefully when you use the tricyclics. And we can also use the MAOI inhibitors. But we have issues with both food and drug interactions with the MAOIs that can raise your blood pressure tremendously. So you're looking at a stroke if you mess this up. For psychotic symptoms, what are we going to use? Antipsychotics. Don't make it hard. You got psychosis, you want antipsychosis. Don't make it hard. All right. And mostly, when you're thinking of the psychotic symptoms, we're using most of these as PRNs more than anything else when the patient is stressed. So treatment. Remember that often patient hospitalization is only indicated where safety is an issue, and I keep going back to safety. They basically get a point where they decompensate, and they can, when they enter the hospital, because they're decompensating, they will quickly become dependent upon the hospital in all sorts of ways, not all of them positive. Medications too are limited, as I said, in their usefulness. So in many cases, depending on medication use, we worry about addiction. If they start, somebody says, oh, you're very anxious. Oh yeah, I'm anxious. Well, here, have some Xanax, and pretty soon we have Xanax addict, and they're still anxious. Why? Because we haven't solved the problem. So benzos are used in the treatment very limitedly in borderline personality, but just simply due to the abuse. Okay, individual therapy. Individual therapy is really showing some promise here. It helps increase trust, slows and interprets the isolation, provides support, helps decrease anxiety. Group therapy, oh, this is really great. If you're in a room full of people just like you, and somebody points their finger and says, you have this disorder, and they go, oh, no, I don't. But if the other 9 people in the room go, oh, yeah, you do, it's kind of hard to argue with 9 folks. So the power of the group, and also the power of the group to say how you can do things better. So folks really do get a lot out of group therapy, and I'll come back to that shortly. In CBT, it's cognitive restructuring techniques that are used to stop the negative thoughts, change them for positive ones, including decatastrophizing, which we used in anxiety, showing great promise with borderline, especially dialectical behavioral therapy. That's now considered the most effective treatment. That's in your text, so you shouldn't miss this part. All right. So if you've got a borderline patient, we're looking at a form of CBT, which is dialectical behavioral therapy. Basically, it's, especially those that have a high risk for suicide, that's a good choice. So how do we, when you've got patients, you notice that we've kind of gone through all this stuff, and some of it is familiar, but some of it seems kind of like gobbledygook, and we're kind of, it's like it all sounds alike, it all looks alike. So how are we going to tell them apart? These are similar. We've got similar names, schizoid and schizotypal. So how do we do one from the other? How do we kind of clinical path? So you're going to go, let's say you're a part of a mobile crisis and you've been called out by the police and you've gone to a gentleman's house who's known to be paranoid. What are you going to see? And so, you're doing these kinds of things, and at some point, you're going to kind of look around for, there will come a knock at the door, and what comes to the door Who's this? Who are you? What are you doing here? Get off my lawn. What do you mean you're here from the hospital? I'm not in the hospital, but you're going. This is what you're going to see. Now, whether you see the helmet and the face, you will see the attitude. And it'll be there strong. That's paranoid. They're already dug in. Get my drift? So, paranoid personality disorder. We've got pervasive mistrust and suspiciousness of others. Oh yeah. You know, who are you and what are you doing here? It's more common in men, sorry guys. It's about 0.5 to 2.5% of the population. They rarely seek treatment or stay in treatment. Why? They're paranoid. Don't make this hard. Very good. That's it. They're already paranoid. Now, we give them an antipsychotic. Is that going to help?
No,
Why?
because then you're still going to have a paranoid person.
You're still going to have a paranoid person because it is a lifelong pattern of behavior. Don't leave that thought behind. Okay, so they're guarded, they're hypervigilant, they use projection, they blame others. You know, it's all them people in Congress that you got to, all that kind of stuff. So you hear this. In fact, if you want to see a good example of paranoia, go on, let's see, CNN, Fox, CBS, NBC, doesn't matter, pick one, and you will see it. You will see the paranoia right then and there. And the comments on the things, that's where you really see it. I mean, the internet brings these guys out. Nursing interventions. Number one, gaining trust. I'm going to tell you good luck with that, but I'm going to tell you what happens when you do. Gaining trust is very, very difficult. It's a major goal and should be a straightforward approach. I've got it in bold for a reason. Straightforward approach. Do not lie to these people. Do not tell them anything except about what you're going to do. You got a paranoid person and they need to go to seclusion, you say, sir, due to your behavior, we're going to seclusion. Don't lie to them, because they will never forgive you for that. They're not going to be happy with you in taking them to seclusion, but they will at least know what's happening. And you can come back later and say, remember when I said you were going to seclusion? Yes. Did I lie to you? No. And that'll start the trust. It may not be that they like you, that's okay. Can they trust you is the big thing. These persons will remain suspicious even if given an antipsychotic medication, as we just said, which means that a person with this disorder may always find medications and treatments as objects of suspicion. And that's the thing you need to keep in mind there. All right. Help the patient validate ideas before taking action. Well, I think they're out to get me. Well, let's talk about that. Tell me why you think that, and let's run that through. It's like you think that somebody on the news is out to get you in New York. Do you live in New York? No. Does he know your address? No. What's the likelihood of him out to get you personally? You have to go through it like that. Now, using logic, you kind of keep in mind that these are not always logical folks, but keep at it, and eventually you can kind of bring them down from that. Does that make sense? Okay. All right. Now, we've got schizoid. Well, these are a little different kind of folks. They make really good folks for other things. Hello. My name is John. I know it's kind of hard to hear me from that. They are robots. That's the thing. They have a pervasive pattern of detachment from social things. They're robots when you look at them. They can be very lonely. Let's see if I can, hard for me to lecture like that. I'll just leave that up there. They're very lonely folks. They show little emotion even when they can feel it, because they're just not making that connection between emotional outlook and what they feel inside. They don't plan well, and they don't engage in regular life events. They often sit around in their parents' basement or their siblings' homes, and they're able to perform in vocational settings, and they can be contributing members of society. It's just that they tend to be put off from those things. So they don't report distress from a lack of emotion. They appear very cold when they're really not. They lack future goals often, not always, but often. And they're often intellectually accomplished. So you can see people that have higher degrees that also are the robots. They have that personality trait. How many PhDs have you seen that I kind of wonder, does that happen when you get your PhD? Did you become this? I don't know. Focus on community and social functioning. That's what they don't do well for nursing. Use housing and vocations that accommodate solitude. By the way, they make great folks to work in IT because they're working with computers and not other things. And I've known a lot of IT guys, and I'd say probably a good third of them are this trait, if not the disorder. And they do quite well because they can focus on what they're doing, and they're highly intelligent. But they're very much a loner, and they're a little bit afraid to interact with all the rest of us. Help the client maintain any current relationships they already have. If they've got a relationship with somebody, we don't want to destroy it. We want to encourage it. And that includes getting a good case manager for both advocacy and consistency. They need the consistency because they don't make friends easily. I have a young gentleman that happens to be an engineer, of all things, and he's on the spectrum, as we say, and he is a little bit on the schizo personality. However, over the years, all my buddies and I, we've kind of pulled him in, and he's brightened up. Even his parents called us up and said, we've never seen him come home and talk like he does after he goes out with you guys riding your bikes. He has begun to blossom. Now, when he's at work, leave me alone, I'm going to do my thing, I'm an engineer, thank you very much. But you get him outside of that, and we've actually begun to slowly get him into socialization. Okay. Schizotypal. Oh, bless their hearts. These folks are even more eccentric. I know. Hi. Now, would someone wear this in public? Yes, they would. I know a gentleman that wears one of these in public, and he has this disorder. Bless his heart. And I know that because he has all the other traits, and I'm going, got his diagnosis down pat. Now, why, when you're wearing this, would you do this in public? It's because they are more eccentric. That's the thing. So let's look at the pattern of these folks. They often look odd, which makes them someone that we would normally avoid in polite society. They avoid relationships because they just don't understand relationships. And as noted, this disorder may be a precursor often to schizophrenia in about 20% of the cases. That's an important little point, is that we know that folks with this disorder often develop schizophrenia 20% of the time. So don't leave that out of your thinking with these folks. They struggle with keeping jobs because of their odd behaviors and looks. They lack hygiene, which doesn't help people in social situations. And they have bizarre thinking, very similar, but not quite the same as schizophrenia itself. This is one of the few personality disorders where medication, specifically the antipsychotics, are somewhat helpful. Mainly because we're stopping that budding schizophrenic, those 20%, from going on and having difficulty. So they have a pattern of social interpersonal deficits, affects about 3 to 5% of the population. Again, more men than women. Perceptual distortions, behavioral eccentricities, and as I said, about 20% do eventually develop schizophrenia. The sad thing is that about 10% of them will also commit suicide over their lifetime. And that's the really sad part, because they get ostracized. They're so strange that society kind of kicks them off, and they get very, very lonely, and they get very depressed on top of all this other stuff. And they do, at times, commit suicide. Nursing care. Self-care and social skills assist. They don't bathe, so you got to help them with that. They put on too many clothing. It's the middle of the summer, and this gentleman that I mentioned, he's got about 6 layers on. along with his hat. Where's my propeller? Gotta get it going again. So that's the thing. It's like he can't be comfortable in that. So you have to talk to him about what's appropriate because they don't know. And that's where they get into trouble. You want to role play, especially in group or individual therapy, interactions with potential contacts to help the client learn how to respond. So you let them practice in group. So you're going up to McDonald's and you're going to order. How are you going to do that? Ever? It's like, no, let's try that again. You know, let's make sure that you're getting this down and let them practice those things. If they see somebody that they want to talk to, well, how do you do it? You don't walk right up to them and go, hi, how you doing? You know, that frightens people, especially today because they're all down here doing this and they don't know you're coming. So you're right there. So we need to make sure that these folks practice these things before they get there. All right. So question. True or false? Cluster A personality disorders are characterized by dramatic and emotional behaviors. False. That's correct. It's the odd and eccentric. All right. Cluster A personalities are characterized by dramatic and emotional. That's false. It's the odd and eccentric behaviors, cluster B personalities, that are characterized as dramatic, emotional, or erratic. Okay, when you're working with a client with paranoid personality, the nurse would use which of the following approaches? Serious and straightforward, very matter of fact, very good. All right, serious and straightforward. Oh, now we're going to talk about one of my less favorite folks. All right, antisocial. You just know there's a hack coming, right? What's it to you? I'm talking to you. It's the gangster hack. So I got the gangster thing in. With my apologies to all the gangsters that are out there. But it is that thinking that goes with this. So the clinical picture of antisocial personality is right here, and I want you to understand this very clearly. They smile, they scheme, they plot, they plan, and they really don't give a hoot about anyone but themselves, to the extent that they will lie even when the truth will do. That's significant. That is significant. Just because of habit. I often wonder if they really understand what truth is in a real sense with borderlines, or I'm sorry, with antisocials. So pattern of disregard for and violation of the rights of others. That's the term, violation of the rights of others. It's kind of like, you know, I need a car. I got a car. You might get these back, you might not, because I need the car. Is it your car? Doesn't matter. I need the car. Does that make sense? It's, you're looking at things that is, if they need something, they take something. And it's all about them, very egocentric. So when you're looking at them, affects about 3% of the population. 3 to 4 times more men than women are diagnosed with this disorder. Now the question is, because when we talk about borderline, we're going to find that the opposite is true as far as the numbers go with females. So is this a cultural bias against men that we say their behaviors are antisocial and women are borderline? We're still kind of debating that. There are differences between the two, but there's also a lot of similarities between the two. 50% of the prison population in some studies have this diagnosis, which doesn't surprise me. Onset is in childhood or adolescence, but formal diagnosis is not made until age 18, when we know that those patterns have been made. Because a lot of people display the trait, but they never develop the disorder. And so it's kind of like, okay, we can't, you know, you're 5 years old, we think you're a budding antisocial, but you may not be. Some of the things we see, it peaks in the 20s and diminishes after about 45 or 50 by the time they're in prison, so they don't have much damage they can do. Poor impulsivity and judgment. There's also a lot of thrill seeking. It's like they can't, you know, I think I'll go rob something. You know, I was listening today, some guy in Florida came in and it was right after the store was closing and he couldn't get beer, so he goes, well, if I can't pay for it, what if I steal it? And she goes, well, I'll call the police. So he stole it, she called the police, he's sitting in jail. You know, you gotta think things through. They just don't, they have a lack of remorse, and that's why I've got it in large letters there. Now, normally, they appear quite normal, they can be charming. We have a lot of elected officials that come under this. You know, they're very charming, thank you very much. We have some folks in Hollywood that also come under this, but they are not nice people. All right, they display a lot of false emotions to use to their advantage. When I say false emotions, they really don't have a good sense of what love is. They don't have a sense of what like is. They don't really do those things well. Does that make sense to you? So they don't, when they start to get down and try to find out what they feel, they don't feel much because it's really shallow. So let's talk about a profile here. This is from the website, Profile of a Sociopath. They are superficially charming, they're manipulative, they have a grandiose sense of self. I'm the best thing out here, so you know. Pathological lying, lack of shame or guilt and remorse, shallow emotions, which we've mentioned, incapacity for love. Oh, they'll tell you they love you, but it's because they want something, not because they really love you. Need for stimulation. They're bored from the time they get up to the time they go to sleep. So that's why they're always looking for something to get into. Lack of empathy. You know, if you get hurt, well, it's too bad. Poor behavioral control and early behavioral problems. We see this in children that we know may develop this, and so we see that possibility there. They have a lot of irresponsibility. They're very unreliable. If they say they're going to show up at 10 o'clock on a particular day, don't put money on it. You know, they might show up, they might not. Is it to their benefit to show up? They might, but if it's not, they're not going to be there. They have a parasitic lifestyle. They live on others. Remember the car? I have a car now. You'll never see that car again. Money, they'll take money from people. They'll have girlfriends that, you know, hey dear, you know, I need $50. Me and the boys are going out. I don't want to look like an idiot, so you know, I need money. So they get other people to work for them, and they're a parasite. They live in other people's houses often, on their couch or wherever. And often they get into criminal, but also entrepreneurial versatility here. They make good used car salesmen, they really do. And they come up, you know, if you see some of these things on TV, the infomercials and so forth, I guarantee you there's a budding sociopath in there somewhere from some of the things that they say. You know, buy this wonderful water, it's going to save you and make your life better. Just send me $50, I'll send you a tube, buddy. You know, and we go, okay. And you get that tube, but look, I got $1,000 in the mail. That little, you know, tube worked. And it's like, no, it didn't. You were getting your return from the government anyway. So, you know, they really push those kinds of things, and they prey, P-R-E-Y, upon the rest of us. All right. Main distinction between a psychopath and a sociopath, I do want to talk about those terms very briefly. It used to be that we often use these two terms interchangeably, but we've done a lot more research into criminology, and so there is a distinction between the two. The main distinctions are in a psychopath, there's no sense of morality or empathy for others. But in a sociopath, there is a sense of morality, it's just not the same as the parent culture. In other words, their sense of right and wrong does exist, but it's not the same as yours. And environmental factors seem to be responsible for the preponderance of symptoms in the sociopath, whereas in the psychopath, both environment and genetics play equal parts. So, for the most part, psychopaths tend not to plan their violence. They're too impulsive. But sociopaths, they're very meticulous. They'll plan for hours, days, weeks to do crimes, to do other things to you. Both sociopaths and psychopaths are easily bored and will seek attention from others, and they go to extremes to get it. So there we are. Nursing interventions, all right, this is where it gets important. We want to validate all information from a client. They're not truthful. So no matter what they tell you, what do we have to do? We have to check it out. We have to verify it. Every last little detail. Well, I do use this pharmacy over here, okay. How many other pharmacies do they also use? How much are they telling you that's the truth? So we have to validate everything. Don't believe, if they tell you the sun is up, you have to go outside and look. I mean, you know, it really is. Encourage the client to identify their actions that lead to hospitalization or incarceration. And this is where in group or in individual therapy, we say to them, so tell us how you got there. Well, those people, no, not those people. What did you do? And it takes a while. And finally they say, well, I stole the car, but I really had it. It's like, no, you stole the car. That's why you got here. So let's talk about what you did to get here. And you get them to start recognizing their individual responsibility. This is, for them, remember, this is a lifelong pattern of behavior. It's going to be a lifelong pattern of therapy for us to deal with them, but that's what has to happen. Identify unacceptable behaviors and confront them. Develop specific consequences for any unacceptable behavior. Give positive feedback for honesty, because remember, they don't know when things are honest. So when they finally do tell you the truth, you praise them for it, they kind of go, what? I mean, I got something positive out of that? You're trying to get them to want to do that again. So you do want to reinforce that. Avoid defending or discussing why rules exist. Okay. This is one of the best things I can tell you. You got a rule, that's the rule. We're done talking. So, 9 o'clock comes, lights out. They're not going to turn out their lights, I guarantee you. You're going to have to fight them every time. So, when you go in, lights out, clean. But I want to stay up. They're always going to see themselves as special. Why do I have to stay up? Why do we have this rule? We have it. That's it. We're done talking. Move on. Because they're always going to push the limits. Does that make sense? Kind of like a teenager at home. They're always going to push the limits. But these teenagers never did grow up emotionally. And finally, inform the client of consequences of behaviors prior to their occurrence. In other words, tell them up front, with these behaviors, these are the consequences. And if you have a rule and a consequence, you better follow through with it, because they'll push that point over and over again. So always, always, always follow through. You have to be consistent. And that means you and your staff have to be consistent. Everyone has to be on the same page with this person. All right, so we're going to use limit setting techniques. You state the behavior, you identify the consequence, you identify the expected or desired result. When I say it's lights out, I expect what? The lights to go out. Be sure and always follow through with limits or consequences. We have to be consistent. That's the big thing with them that they're going to push for, is they're going to try to find or drive a wedge between staff when they do it. Point out or teach the client's responsibility for his or her behaviors, and we're going to use confrontation as to help manage deception and manipulation. We're going to walk right up to them and say, you did this behavior, this is your consequence, and away we go. All right. Avoid splitting by staff of the staff by patient. We're going to talk more about splitting when we get into borderline, because the antisocial and the borderlines are the most likely to split the staff. And how that works is, in splitting the staff, you go to somebody and you say, you're the most wonderful nurse there is. But those night shift people, you know, gosh, you gotta watch them. Then you go to night shift. You're the most wonderful nurse there is, but you know those day shift people. And pretty soon you've got day and night shift that are arguing with each other. And the patient's smiling. If I see one of these guys smile, I worry. So that's the deal. Okay. We're going to stop here and take a short break. Okay. All right, we're going to, now that we're back, we're going to be talking about borderline personality disorder, named by existence. These are unhappy, unstable, all or nothing folks, and bless their hearts, they don't want to be this way, but they are, and they're not very nice folks. So they're kind of odd in that sense. So we're going to see what we can do here. Okay. Hi. You're wonderful. I hate you! Hi. You're wonderful. I hate you, I hate you. They're two-faced. By the way, that's the Hulk back there in case you're wondering. And that's a borderline. All or nothing. They either really, really like you, which is always scary, or they really, really hate you, which I feel much better about because I've done something right usually. That's the thing. All of you, when you think of me as a professor, you think of, well, that's Mr. West. There's some things I like and some things I really don't care about, you know. But you put those together and it's like, that's Mr. West, and you're able to live with that. Borderlines cannot. Borderlines have to be all or nothing. What do you think that does to their relationships?
It destroys
It destroys them, that's correct. All right, so we're going to look at this, you know, I talk about borderlines, just shoot me now. Because these really are some of the toughest patients, and bless their hearts, they did not start out this way. I'm going to talk to you about how they got there, and it'll probably change your mind about your feelings about them. It's related to trauma, much like multiple personality disorders, or DID, which means that they were in some ways created. Again, like the antisocial patients, the staff needs to communicate very well with each other, prevent splitting, and you must be consistent. Unit rules must be enforced rigidly, or they will ignore all rules. They're notorious for that. And as I said before, dialectical behavior, a form of CDT, is now the most effective treatment for them. We had a therapist several years ago, Helen Ross McNabb, that had nothing but borderlines in her group. She worked with them for 5 or 6 straight years and kept them out of the hospital. And finally had to stop because I can't take them anymore. But she did a wonderful job for them, and actually so well that most of them, even after the group was over, did not come back into the hospital. They were not cutting on themselves. They were not being destructive. So she had done a wonderful job. Often they engage in non-suicidal self-harm. That means cutting, but not with the idea of harming themselves, other than the cutting itself. They will be very clingy. They're frustrating. They have all or nothing thinking. So it's a pervasive pattern of poor or unstable relationships. When we say borderline, it's like, okay, I am sitting over here between this personality and that personality, or this thought and that thought, and so they're just kind of sitting there going back and forth all the time. There's a fear of abandonment to the point that they will pick an abuser to live with rather than get rid of the abuser because they have to have someone there. Does that make sense? So they often choose poorly. They have chronic emptiness, which puts them at huge risk for depression, and of course they're going to self-medicate for that depression with drugs and alcohol and anything else the doctor will give them. They have what's known as labile mood. You know, I'm happy, I'm sad, I'm happy, I'm sad. They go back and forth. The mood itself is unstable. They have polarized thinking about themselves and others. That splitting, it's all good, all bad again. They have a lack of insight. You try to get them to think logically about how they got where they are, they don't get there. And it's like you're just kind of spinning your wheels off and trying to get them to see how they got there. Transient psychotic symptoms, especially when they're stressed. And also, if you happen to have them in the hospital, bless your heart when you are, because they will be very destructive on the unit. There will be a constant source of irritation to other patients. And if you put them in the room with someone that has schizophrenia, within a few nights you'll have 2 people that are acting like they have schizophrenia. Remember the borderline? You take them out of there and put them in with someone that has DID, and all of a sudden you have 2 people that are saying, I have DID, because, again, they don't have a good sense of themselves, so they glom onto whatever's there. And they, unlike DID, these folks tend to be very dramatic. In other words, they'll come out of the room going, I'm switching, I'm Bob. You know, it's like, really? Most people that have DID are not that dramatic. They switch, and it's dramatic enough on its own. But these folks will run to the middle of the room and make sure that everybody knows they're switching. So, recurrent self-harm, self-mutilating, and a lot of suicidality. Remember what I said about borderlines and suicidality. They really don't expect to die, but what happens when you keep trying? Eventually you die. They screw up. And if we can get them to stop that behavior, we got a shot at having them have a life. But they're always impulsive, very impulsive. Okay, so interventions. We're going to promote safety. Remember safety, our number one thing here? We're going to be talking about no self-harm contract with them. We're going to allow safe expression of feelings, because feelings are something that are buried in them and will be coming out all over the place, but they're not really, they're often very shallow, much like the antisocial. Help patient identify their feelings. That's one of the things they struggle with, because they are borderline. They never know exactly quite what they feel. So we have to dig a little deeper with them and let them feel and figure it out. Encourage journaling. This is very similar in some ways to DID, in that journaling is a great tool for the person that has borderline, because it helps them write their thoughts down so that they can read it later and get a feel for their feelings, so to speak. And I've watched it work very, very well with them, because they weren't aware of how they were sounding until they saw it in the journals. Decatastrophizing. You know, if you lose your Coke can, the world's not going to end. You know, if you have a flat tire, the world is not going to end. They'd be on the side of the interstate going, "Save me!" You know, and everybody's trying to avoid it. But that's just the way it happens with them. Whereas everybody else would say, "I've got a flat, pull over here, call AAA, stand back and wait. They'll be here and fix it." But not with the borderline. It's always dramatic. Okay. So safety is the big issue here. Take all suicidal, self-mutilating type thoughts and gestures very seriously. That's the number one thing. Safety is going to be the thing. They often are truthful. They're often not truthful, much like our antisocials. And they're very impulsive. It's the impulsivity that's going to kill them. Always watch them for suicidal and homicidal ideation, even when they say they're not suicidal. Do not believe a borderline. Just go, and keep watching them, because they can switch on you in a moment to a, I'm going to hurt myself mode. Verbal no self-harm contracts with them are worth the paper they're printed on. Think about that for a second. It'll occur to you why I said it that way. Verbal no self-harm contracts are worth the paper they're printed on. They may or may not help with borderline patients, and may actually be harmful by putting a wedge between the patient and the nurse. So be careful with those. We do want to ask them how they're feeling, whether they're suicidal or not. But can you believe them if they tell you they're not suicidal? And the answer is no. So we have to just kind of take that with a large grain of salt and move on. These patients will make lethal attempts, but they're ambivalent regarding suicide. Now let's look at that term, ambivalence. Most people think ambivalence means wishy-washy. That's not what it means. Ambivalence is very strong feelings in two directions at the same time. They're being pulled very hard. I want to really kill myself. I really don't want to kill myself. They are ambivalent. So I want you to remember the term ambivalence. It's a very strong thought in two different directions. Okay. That makes them very gaming, is the term we use, and very dangerous. So we want to help them identify their feelings. We want to help them structure their time, teach social skills, use limit setting, just like we did before, and assist with cognitive restructuring. This is what the dialectical therapy will do. The thought stopping when giving negative self-messages and encouraging positive self-talk. One of the things we do is positive affirmations. We put a little list of things that pretty much they can come up with that they're good at. We put it on their mirror. And every morning they get up and say, okay, I am a good person. I can do these things. I can do this. And we have them repeat that over and over again, because we have to put it in from the outside. Now, how did you get your borderline? Remember the trauma? It's usually of a kind of abuse type, so either sexual abuse, physical abuse, or emotional abuse, or all three. So when you're dealing with a borderline, and you're at your wit's end, and you've pulled out every hair you've got, which explains why I don't have any, then you have to think back, how did this borderline come to be? It came to be because someone else abused them at an earlier time. And so if you want to be mad at somebody, don't be mad at the borderline, be mad at who made it. Special issues with them. These patients often decompensate, that means they get worse in the hospital, so we try our best not to put them in the hospital. We try to keep them on an outpatient basis and keep our hospitalizations short, because they will decompensate and they will make it their mission to stay in your hospital and be a pain in your side, usually the back side. Constantly at risk for self-mutilation and suicidal gestures. They make very poor judgments regarding being rescued, which I've already mentioned, and they will try to split staff constantly. It's the staff splitting. If you're in a treatment team and you hear two staff arguing about the patient, 99 times out of 100, everyone will stop and go, oh, we've been split. Oh, we have a borderline. Because the arguments come from that splitting. And so it's like, oh, wait, we're all in this to take care of the same patient. Oh, we've been split. So that's what you need to understand. They're going to try your patients, and this is where countertransference comes up. Transference means that the patient views you as somebody in their own life, like where you're just like my ex-wife or whatever. That's transference. Countertransference is where I, as a therapy, go, God, that patient is just like, the last 6 patients I had. Oh, God, she's going to be awful. I don't know that for a fact, but I'm doing countertransference. And so we have to be careful of that. We want our patients to succeed, but we don't want them to have suicide. You really do get frustrated enough, you want to say, look, you're cutting this way, quit that, and cut this way, it works much better. Don't do that. And so I'm saying you will get frustrated. Watch each other. When you work with other nurses, and you will in these situations, then don't keep the same nurse getting pounded by that same borderline over and over again, switch it up from time to time. Let somebody take a break. Because if you don't, they're going to want to kill this person. And we want our nurses to succeed just as like we do our patients. Because they will get overwhelmed. Also watch your mental health associates, your program counselors, whoever is the line staff out there, nursing assistants, because they too are going to be beaten up by the emotional aspects of the borderline. So we need to make sure that we swap them around too, so you don't have one person constantly watching the same person having to deal with this very, very manipulative person. They're going to try to sabotage their own discharge, and they really are. I worked with a very fine psychiatrist, who I will not name at this point, but she knew borderlines very well. And the interesting thing was I had a patient that came in, and here was the scenario. The patient was a borderline, as was her husband, and they were married. So you can imagine the chaos these two created. And they were from out of state. And they were having an argument as to who the craziest was. So they pulled into the nearest hospital, which happened to be ours, on their vacation. So while the husband is inside trying to convince the doctor that he's the crazier of the two, the wife is in the car with a razor blade that you cut hair with, sawing away on her arm to prove that she was the craziest. Now, our local dentist who worked at our hospital at that time was on his way out and happened to see the young lady sawing away on her arm and, of course, attempted to stop her. And pretty soon, he's chasing her around this bush outside the admissions building. And I'm thinking to myself, okay, because I'm going out to get med. I'm going to another building. I'm just, going out and pick up some medicines. And in those days, which was, about 40 years ago, when you saw two people chasing each other around the bush, they got building privileges, it's okay. You just didn't pay much attention to that unless somebody was screaming. So I'm walking out there and I heard my name. Bill, I need help. And I looked up and it's like, it's the dentist. Why is he chasing someone? And then I saw the razor blade. It's like, oh. Run over, the two of us stop her, get the blade away from her. Now I'm holding on to make sure she's not bleeding to death, We get her inside, stare strip her. The psychiatrist speaks to both of them. Now they're both happy. See, I proved I'm crazier than you. Well, yes, you did. We're good. They did not admit either of them. Why?
Joined up to tear apart.
They would have gone into a urinating contest, as we say, trying to figure out which one of them could be the worst on the floor. And they were perfectly happy and safe at the moment that we discharged them, or sent them on their way. Does that make sense? We had the razor blade, so that was taken care of. We'd stair stripped her up. It wasn't that deep, as it turned out, so all of it was superficial. So it was like, okay, they're safe to go. Don't admit them at this point. Let them continue on their vacation, and they were perfectly fine. So we have to be careful with them, because if we bring them into the hospital, be prepared that they're going to decompensate at that point, and it's going to get much worse. So, all right. Oh, now we get histrionic. I love the histrionics. Okay. My fingernail is broken. That's a histrionic. By the way, this is my feather boa, in case you're wondering. And for those of you that don't believe me, this is my wife's feather boa. This one's mine. And it's bolting. Okay, this is your histrionic. My fingernail is broken. If you go to YouTube and look at some of that stuff on Facebook, what do you find? Histrionics all over the place. They're having a blast. So, when you're thinking of histrionics, they are pervasive pattern of excessive emotionality, attention seeking, thus the BOA. Seen more in women than in men. It's about 2 to 3% of the general population. These patients use a lot of exaggerated emotional expressions. Everything is over the top. He's one of the most wonderful doctors I've ever thought about seeing. And you've not seen the doctor yet, but he's the most wonderful. Really? You haven't seen him yet? You're already saying that. They want to be the center of attention. That's the BOA. And they often use illness to draw attention to themselves, fainting, falling down, the Scarlett O'Hara syndrome. Rhett, I'm falling, and away they go. And I'll have to tell you the story about we had a lady that met this histrionic, and she came to our hospital, and the first thing she did was she went to her room. Now, this is a very large woman, about 350 to 400 pounds, big woman. And she decided to take off all of her clothes and run out into the middle of the day room where everybody was, male and female. And she did, as she ran out in the room, she hollered out, did a pirouette. I never thought anybody that weight could do a pirouette. And she spun completely around and hit the floor like, boom! Everybody in that building heard it, all the way down, because she shook the whole building. And then she laid there doing this. It's like, that was not beautiful. So we're looking at her, and we get a sheet and roll her onto it, and she weighs so much that we had to get 2 sheets because we tore the first one trying to move her, and she was wet, which she'd been in the shower, I guess. So we get her to her room, and we're about to put her in the bed, and she weighs more than we can lift. So we cover her up very carefully, and my friend and I are standing there. We're both RNs. And we put a pillow up under her and said, we'll wait till she wakes up. We'd taken her vital signs and those things, everything was fine. And then she starts doing this. And my friend looks at me and goes, what do you think's going on? I go, I don't know. And she goes, I'm having a seizure, I'm having a seizure. And it's like, well, thank you for telling us, we didn't know. And we left the room. I did leave a staff member sitting outside the door just to make sure that everything was fine. But she was histrionic. And that's what we were seeing, this very dramatic kind of stuff. So, they're very flamboyant. They often have vague physical complaints that they exaggerate. They're looking for secondary gain. Remember secondary gain? So they get into the hospital, I have pain. You got Demerol? They're looking for that secondary gain there. So we're looking at nursing interventions here. You're going to give appropriate feedback on social interactions. When they're over the top, you tell them they're over the top. And it's like, tone that down a bit because they really don't understand that. Explore client perceptions. What do you think you sound like? What do you think you look like at this point? Because they'll often tell you something that they think they're being normal or within the norm when they're really not. So you have to kind of reset that for them. Encourage I statements instead of, well, those people, it's like, no, what did you do? It's like, well, I did this. It's like, okay, now we're on the I statements. and teach them social skills and role play. You need role play. They'll love role play. They always volunteer for it. But when you finally get to role play with them to tone it down, it's a little bit harder for them, but they need to do that. They need to know what the norm is, because they really don't know. All right. Okay, narcissism. Oh my. Can't wait, can you? I am the king. Well, that looks pretty good, doesn't it? After all, I am the king. Get my best view here. Okay. This is narcissism. Narcissism is a pervasive pattern of grandiosity, fantasy behavior. I am the king of the world, basically. It's from the Greek story of Narcissus. For those who don't know Greek mythology, I'm going to tell it to you. It's a mythological person that was lured into looking at his own image, whereupon he fell in love with himself, and he died lonely and broken-hearted because he couldn't be with himself. Basically, these folks don't recognize or empathize with the feelings of others, and that's one of the big issues here. They have a perceived greatness about them that doesn't necessarily show up in real life. There's a lot of people in politics that think they're greater than they actually are. There are a lot of actors that think, I'm a great actor, and you look at their body of work and you go, no, you know, so John Gielgud was a great actor. You don't qualify. I mean, so you have to think about what they think of themselves. Self-esteem here is always fragile with them. They can be somewhat successful in business related to their ambitions or overconfidence. In other words, they're willing to take risks because, well, I can make $1 million, watch me. And sometimes they risk, and they're not necessarily stupid people, they tend to be fairly intelligent, so they sometimes make that $1 million, and that just kind of reinforces the fact that they're great. So they do tend to do that, but they also suffer when their little fantasy ideas don't work out, so they don't do as well with that. So we've got this pervasive pattern of grandiosity. It occurs in about 1 to 2% of the population. 50 to 75% of these flamboyant folks are male. Sorry guys, but we're the peacocks here, okay? Narcissism traits are common in adolescence. Go to any high school or junior high, you'll see them everywhere. It's kind of like, you know, they go, they're making sure their hair's right, they've got them, I'm looking good, you know, they're doing all this kind of stuff, and it's typical adolescent behavior, but it's not typical adult behavior, and that's the thing here. This is, and by the way, just because you have that trait as an adolescent doesn't mean you're going to develop it as, or develop into this as an adult. Obviously, most of us didn't. I think it's really interesting when you look at either high school seniors or college seniors, either one, you start seeing people become independent and individualized rather than following the herd like sophomores do. Sophomores all, you know, I want to be completely different, and they dress just like every other sophomore that's out there. Seniors, on the other hand, have become independent, and they start wearing clothes that nobody else wears or doing their own thing. They become much more individualized, and it's a wonderful thing to watch because you know that they're beginning their adult thinking at that point. These folks are often very arrogant, they lack empathy, they will belittle and discount others' feelings. Well, after all, I am the king, you need to go get my medicine. Hop to it. I mean, they really will, and well, you didn't get my medicine? Well, good. Sorry, it's an excuse for a nurse I've ever seen. And they will do things like that. And of course, you're sitting there going, what did I do? You didn't do anything. You just happen to have a narcissistic person on your unit. And so they will belittle you on a regular basis. They have preoccupied with the thoughts of ideal love, we're back to Narcissus again, and they have limited insight. They really don't see what they're doing is wrong. So you're going to have a struggle with them. They have very, very fragile self-esteem. They always expect special treatment, and so when they don't get it, they're offended. That's real life. And so they may have some times when they're just really not doing well, and may become depressed as we do that. So nursing interventions, Be very aware of your own feelings. Don't internalize criticism from these people. And it's, when you're a new nurse, it's hard. Now, when people say, well, you're a horrible nurse, and you're working really hard, and you're trying your best to do this, and somebody comes up to you and says, well, not only are you a horrible nurse, you're ugly too. I mean, you know, really? Well, you wanted a second opinion, you got it. You know. So you have to be careful of these folks. They will pound on you emotionally. You have to get a tougher skin, because you got to remember the source it's coming from. Okay, so don't buy into it. Do not be doing self-affirmations for yourself. If I am a horrible nurse, I am ugly. Don't do that to yourself, is what I'm saying. You need to make sure that you're taking care of yourself and your peers. These are going to be some of your toughest patients because they are so rude, arrogant, and critical of others. Always use a matter-of-fact manner with these folks and set limits on rude or abusive behaviors. So you need to be careful of those. And explain the expectations to the client, you know, because they're wanting special things. It's like, sorry, you're a patient here, that's not going to happen. And that's the way it is. For example, in one of our special care units, one of the hospitals I work at, they have coffee time on even hours. So 8 o'clock, you get coffee. 10 o'clock, you get coffee. I guarantee you at 9 o'clock, guess who's going to be there? Well, I'm different. I was with the doctor. I was, you know, I got up late. It's like, you get coffee at 10. Well, I deserve to get my coffee. And then tomorrow, get up at 8, you get it. But there's no argument at that point. You keep it the same. Does that make sense? Especially with them. We have to set the limits on them. All right, so transient psychotic symptoms that occur with borderline personality are most likely treated with, don't make this hard, antipsychotics. There you go. You're catching on. All right. So yeah, it's the antipsychotics. We use the other drugs, but that's not for the antipsychosis. We're going to do this. Okay. The nurse working with a client with antisocial personality would expect which of the following behaviors? Select all that apply here. Will they comply with the rules? No, it's borderline. Or antisocial, I'm sorry. Do they exploit others?
Yes.
Yes. Do they seek special privileges?
Yeah.
Yes. Superficial friendliness towards others?
Yes.
Yeah. Utilization of rituals to allay anxiety?
No.
No, that's an anxiety disorder. Withdrawal from social activities?
No.
No. So it is B, C, and D. All right. Avoidant personality. Oh boy. You don't see me. I'll just stand here in the hall. I can see you, but I'm not going to let you see me. That's avoidant. They are people you do not notice because they are into the woodwork. So the hat here is a paper bag. They're characterized by a pervasive pattern of social discomfort, low self-esteem, and hypersensitivity to negative feedback or evaluation. It occurs in about 1% of the population in men and women equally. They want social acceptance, they really do, but they fear rejection. So for whatever reason, that's the thing. They want to be a part of society, but they're afraid of being rejected. So they often need excessive reassurance before forming relationships. Are you sure I'm okay? Am I dressed okay? I mean, really, are you sure? Come on, you can tell me. Oh, you're just kidding me along. No, I really can't go because you're not telling me the whole truth. I mean, they're going to wear you out in trying to get positive reassurance from you about just about anything. They fear rejection. They may be successful in some occupations, especially pleasing supervisors. We see a lot of these guys as yes men. In most organizations, you're going to find yes men. The problem for the organization is that yes men are not telling the organization what they really need to hear, they're telling them what they want to hear. Does that make sense? So if you've got a strong personality that's in charge, you just want yes men so they can hear themselves, you know, it's probably a narcissistic person that's doing that one. But here we are with these fine folks that basically are trying to hide away. Oh yes, that's whatever you want to do is fine. In general, they may remain in entry positions due to fear of failure. So, you know, they'll be in that entry job 40 years. They'll be in whatever, you know, level they entered 40 years. And that's just what they do because they're afraid of going forward. Nursing interventions, gosh, they need a lot of support. They respond fairly well to CBT, which is good. That changes their internal negativity into those positive affirmations I keep talking about. The nurse should not expect them to change too much or too rapidly because it's going to be a slow process. You're changing behaviors. These are lifelong patterns of behavior. So can we change them overnight? No, but we have to change them over time. And that's really the thing. They need social skills and so forth so that they are using those skills and they're getting those positive things and they're moving forward. And they can do it, but they're going to need a lot of help to get there. I like this picture because it's so true. It's, you know, the business person with their head in the sand because they're just basically trying to avoid everyone that's there. All right. Now we get to dependent. Now dependent's a little different. Let's see if I can find my thing here. Okay. In dependent, the hat is, you know, I've got a hat, but surely somebody else has a hat that's better than me. They're much better at picking hats than I am. You have a hat? I like your hat. Now see, she knows how to have a hat. So, can I have your hat? Please, you're so good at it. Please, I'll trade you my hat for your hat. Please, let me have your hat. Now I've got a hat. By the way, from now on, you'll be giving me all my hats. I don't know how that's going to work for you. Okay, and I'll swap back. Thank you. That's really it. They're looking for someone else to do their job for them. Dependent personality. So when we're looking at this clinical picture, they are masters at getting others to do things for them. Like a drug addict who is a master at getting what they want, the drugs. These folks, working with these people and sometimes colleagues is a real pain. Clinical picture, you have the excessive need to be taken care of. And they're often very clingy. They voice or demonstrate a fear of separation. It's 3 times more prevalent in women than in men. Often they're anxious and pessimistic. They struggle with making decisions. And relationships are paramount because they fear losing them. So they often pick the wrong person because they just don't want to lose anything. Even if it's unpleasant, they want to have a relationship. They've got to have one. So nursing interventions, we're going to help them to express loss, identify their strengths. They may need help doing daily tasks, mainly because they're wanting to get other people to do the task for them. And that's the thing. Don't give advice or make decisions for these people. Well, what would you do? Well, I really need you to do it. You know, because, oh, your decisions are so much better than mine. If you work with colleagues, well, you know, we have a couple of admissions. You're so much better at admissions. Why don't you go do the admissions? I'll just stay here and watch the phones. You know, but the reason I'm really not good at it. You need to do it. So pretty soon, guess who's doing all the work? You are. So you have to be careful of folks that are dependent because they will literally wear you out trying to do their job and yours too. And so that's important. All right. So the hat here is whatever else other people are wearing, not your own. All right, there's a lot of secondary gain going on here with them. They will use flattery, they'll use tears, they'll use all sorts of things to get out of doing their own stuff. So when they do make decisions or they do something, support them. They need to get that support and that praise for having done something correct. Okay, obsessive compulsive. These are perfect hats. And this hat has to be perfect. You know, perfect. So, I have the perfect hat. I'm sorry. This is the perfect hat. It's much better than that hat, don't you think? I'm sorry. This is the perfect hat. And this one's perfect. They need the perfect hat because they are obsessive compulsive. It has to be perfect. The word perfect comes into this definition. So that's what they're. This one's gold. Perfect hat. Clinical picture. It's a pervasive pattern of preoccupation with perfectionism. My father had this trait, drove us all crazy. They have a formal, they're very serious folks. They rarely complete projects because of trying to get it right. And my father did complete projects, but my wife also has this trait, and she's always starting stuff and never finishing it. It drives me crazy because she is a perfectionist in many ways. They often have, when you look at perfectionism like this, or obsessive compulsive people, they tend to have had inflexible parents. So I look back at my grandmother and I'm going, yeah, there she is. You know, she was, everything had to be perfect, so my father picked up on that trait. They are, typically, these folks are not warm and fuzzy. They have a hard time expressing emotions. And there are a lot of folks that are very successful that have this as a trait, not necessarily a disorder. To be distinguished from OCD, the disorder, which has repeating behaviors or undoing, OCPD, which is, in this case, the personality disorder, what's different is the push for perfection. That's the thing that we're looking for here. It's not undoing the anxiety, it's just becoming perfect. That's the thing. So for nursing interventions, you want to help the client for deadlines and make them. And not for perfection. They just need to finish a project. So, you know, finish it, get it in, let it go. To accept less than perfect outcomes. That's really the goal with these folks, because they will literally get bogged down in the minutia trying to do things perfectly, and they want to do it over again. And they want to do it over again. And let me do it again, and I got to do it perfectly. And it's like, no. In real life, good enough is good enough. And then you move on to something else. Change the goals from perfection to completion, and that's really the difference here, is we're looking for completion. So, as children with the inflexible parents or teachers, often it's the teacher that kind of instills this too, the child wants to be loved and accepted, so they try to be perfect to get the attention and approval from the parent or teacher, and that's really where this stems from. OCPD is often confused with OCD, the obsessive compulsive disorder, which despite having similar names are distinct disorders. So generally those with OCPD, which we're talking about today, do not repeatedly perform tasks. What they do is they're trying to look for the perfection of a task. That's what they're looking for. And they're also viewed, as I said before, as being very formal, very serious individuals. It's thought that OCPD is somewhat learned by being around those parents or teachers that are inflexible or controlling. And so they were often expected to be the good or the perfect child when they were young, and that's often expressed later as this need to be perfect. It occurs in about 1 to 2% of the general population, and they seek treatment because of a lack of pleasure in life or difficulties at work. because they're always striving so hard to be perfect, they never get to enjoy anything. You know, if they don't go out and have the perfect fishing day and pull in 10 trout or whatever they're supposed to do, then it's not perfect. They pull in 9 trout, most of us would be thrilled, you know, but no, they've got to have 10, you know. So those kind of things, it has to be perfect, everything they do. They have to marry the perfect spouse. How's that going to work for them? You know, not real well. So they struggle with those kind of things as well. Okay. And they're very concerned with orderliness in all aspects of their lives. They have to do things very methodically. And my dad was like this in many ways. That's because it happened. Okay, I'm good now. Right the first time. Okay. So when you're thinking about perfection, that's really what we're talking about. Okay. Now we're talking about some of these included disorders. In this case, we're talking about depressive disorders. So in depressive disorders, personality disorders, it's a little different. For this one, it's the hoodie. Now, the next time you guys have a break and you go down the hallway, I want you to see how many people you see doing this. Good up. It could be 85 degrees outside, and this is what they're doing. Why? Because they're putting out the rest of the world. And the hoodie is a good example of that. Is, you know, I don't want anybody to notice me, like you're not going to notice the guy in the hoodie, you know? So it really is the thing that they don't pick up on, is that the hoodie, it blocks people out, but the rest of us still notice them. Because we notice there's this guy sitting over there looking kind of strange. So it's a pervasive pattern of depressed thoughts or depressive thoughts and behaviors. It's similar to major depression, except it's less severe. Think of it as major depression light. It's a good way of putting it. They're sad, rejected affect. They persistently are unhappy regardless of the circumstances. They have an inability to experience joy, and they view pessimism as realistic. Does Eeyore come to mind? You know, that's Eeyore. So we're talking about depressive personality. Nursing interventions always assess for the possibility of suicidality. When people are, anytime they are depressed, in any version, light or heavy, we're looking for suicidality. Safety is always going to be our number one concern here. Encourage activity and give factual feedback to them. We want them to do things. We want them to interact because they're not doing it. They're withdrawing. And thought stopping and positive self-talk, basically we're reframing again. It's like, okay, stop doing the negative stuff and let's talk about positive things that you can do here. And finally, teach and practice effective social skills. Again, role play is really good for these folks to learn how to interact, because they probably are interacting with folks, but in a very standoffish way. Okay. Now we have the last one. And the hat is, you tell me if I need a hat. Go on, tell me. I don't have a hat. Why don't I have a hat? It's your fault. I don't have a hat. Where's my hat? You've got a hat. I don't have a hat. I don't have a hat. It's your fault. Passive aggression. So what do passive aggressive people do? I'll get you for that, my Steve. And that's what they try. Okay, negative attitudes and a pattern of pervasive resistance to adequate social and occupational performance. It's about 1 to 3% of the population. Unfortunately, more women than men this time. Sorry, ladies. They appear cooperative or sullen and withdrawal, depending on the situation, and they often adopt a sick role because they manipulate people with a sick role. They have negative attitudes that influence their thoughts. They tend to blame others. They do not accept responsibility for themselves. And they're frequently indecisive. In other words, they're waiting for you to make a decision because then they can criticize it. Does that make sense? Okay. They tend to blame others, as I said, and they resist demands to perform at expected levels. It interferes with the efforts of others, and they often use the role of martyr. And these kind of folks, passive-aggressive, will undermine things. When I was in graduate school, there was a group project that I had, and so my peers and I all got together and we said, okay, what are our strengths in doing this paper? So everyone came up with their strengths, and one young lady said, my strength is collating and typing. I can write a paper like nobody's business. We said, fine, when we get all the research done and so forth, we'll bring everything to you, and you can do this paper and put it together for us. So, true to my word, my partners and I got it all done. I gave it to her in her hand on the date and time specified. 2 days later, I find materials which are due the next day slid under my door with a note. Undone. I didn't have time. I'm on my way to Florida. Sorry. Now, this is a group project for which we were being graded. And the person that was going to do it all is now gone to Florida. How do you think we felt? Yeah. So, my partners and I had to spend all night typing this paper and putting it all together and doing those things. We had a discussion with our professor the next morning. That's something I don't normally do, but this was so egregious that we needed to say something. So it's like, this is not acceptable behavior. So that's what they'll do. They tend to undermine things and they'll be smiling. It's the true backstabber of both employees and patients. And so they're difficult folks to do it because it really is, when we say aggression, it's a particularly nasty form of it. They really want you to fail is what the deal is. And they'll make themselves look good. It wasn't my fault. I did my fault. They'll do things like that. So for them, the trait's bad enough. When you've got the actual behavior, folks get really angry with them, and they can often come to blows. So nursing interventions for them, first of all, help them examine the relationship between feelings and subsequent actions. This is very important because they're not always aware of why they're doing the behavior. Those are buried feelings. They get buried and then they come out in bad ways. So that's the deal with them. Focus on the behavior to help the patient see what is annoying and irritating to others, because they don't get it. Journaling is another way. Again, this is the second one I've talked about where journaling is helpful. And finally, role play to explore connections between feelings and actions, because they don't get that connection and they need to. Okay, elder considerations. We've got, although personality disorders are not initially diagnosed in geriatric populations, remember they've already had lifelong patterns and behaviors, but we will deal with those behaviors in geriatrics. And the good news is with many personality disorders, they tend to stabilize as they get older. I've already told you in the first of this lecture which ones do what. Borderlines and antisocial tend to burn out. And I really, when I say burnout, I have to say this about that. There's some thought that it's really not so much that the borderlines burn out, it's that everyone around them has finally got them figured out and they're not responding to their stuff anymore, or that the borderline is just plain tired. They're just as destructive in their mind, but they just don't have the energy to go and be destructive anymore. So, there is that thought. Bad news, others don't. They have the same patterns they've always had, only worse. In many cases, age seems to solidify some patterns over time. So if you've got some of these disorders, they're just going to get worse over time unless we do something about them. Nursing considerations. We need to deal with the patient, whether good or bad. Those terms need to go out the window. It is your patient, regardless. Especially if they've alienated everybody else around them. Sometimes we, the nursing staff, end up being the only one left who cares about an individual. And they've literally burned all their bridges. So the only people they have left is us. And I've met patients like that. And the interesting thing is, a lot of times, because of the secondary gain of us being accepting of them, they've do injuries to themselves to get back in the hospital because they're treated properly in society once again, by us. And then we have to deal with that. All right, community-based. When would community-based care be appropriate for these clients and when not? I want you to think about most personality disorders by the very nature can and are treated in community settings rather than inpatient settings, especially borderline. Why is borderline not such a good idea to put in hospital?
They can fix the who's the craziest.
They decompensate, that's right. Okay. Treatment will include group and individual therapies and CBT, but also self-help groups. They do well with those. These groups will help them give feedback to their family and friends and coworkers who may be reluctant to help them. Some of these patients will have major mental health issues and diagnoses in addition to these. So what happens is if you have someone who has schizophrenia or bipolar and they also have a personality disorder, it's an interfering factor. Think about someone that's bipolar and has a paranoid personality. Are they going to be always suspicious of the meds they take? Yes. Are they going to be suspicious of all the treatments they give? Yes. And so they're always going, it's a lifelong pattern of behavior. So they're going to struggle with staying on their meds because they're always going to be suspicious. Okay. Furthermore, if you have a borderline, they're going to be difficult to treat with demand medications. And by the way, they'll switch their comments to the doctor as to what their symptoms are so that they can get things like benzos. And if you give them benzos, not only will they be less than helpful, they may actually be harmful to this person because you've just given them something that with a little alcohol they can now kill themselves with. So they tend to be somebody that's going to end up with a second problem, which is addiction. All right, self-awareness. These are very difficult and deceptive patients. By that I mean that the patients look like they're capable of more than they are at many times. Be consistent with your limits, give consequences. They are going to push the limits and yours at every opportunity. Point out the behavior, then set the limit. Be clear with your boundaries. They will try to split staff, so whenever you see arguments in your staff, know that you've been split. Communication. Communication among your staff and your fellow nurses is paramount with these patients to give good, consistent care. So communication is going to be a big thing here. Also be aware that transference and countertransference really come into play here, especially if you've got somebody that resembles one of these patients, you could be guilty of countertransference. And so that's, you've got to let your stuff, be aware of your own stuff when you're here. And be aware not to do for the patient when they need to learn to do for themselves, especially with dependent personalities. Okay, so let's review. We've got the hats here. We've got paranoid, which hat?
Military.
We've got a helmet. Schizoid. We've got a robot. Schizotypal. We've got a beanie.
Is that the one with the airplane on top?
With the air, yeah, with beanie on top. Okay, we've got antisocial. Gangster hat. There you go. We've got borderline. Two-faced, two hats. We've got all good, all bad. Histrionic. Don't forget the purple hat with the feather. I mean, that's your histrionic right there. Narcissistic.
Mirror.
I am the king. Yes, the crown. Avoidant. Paper bag. Paper bag. Okay, obsessive compulsive. The perfect hat. Bless you. Depressive disorder. The hoodie, I'm going to come back to that one. Dependent. Dependent, somebody else's hat. There you go. All right, depressive is the hoodie. And finally, passive aggressive. I don't have a hat, and it's your fault. So, that's it. So there they are. We've got the helmet, the robot, the beanie, the gangster hat, two hats. We've got what I consider the pimp hat. The crown, the paper bag. We've got the bowlers. We've got somebody else's hat. And we've got the hoodie. And finally, no hat at all.
What was the
Okay.
dependent?
Dependent is your friend's hat, somebody else's hat.
Okay.
Yes. And finally, we come to the last thing. This is, as I looked, the screen, his hat blew off. My screaming. Interesting little corollary here. This is a red sunset, and it was painted in the 1800s. Those colors that you see are not the artist's imagination. They were really that color that year. The reason was a certain volcano by the name of Krakatoa blew up. And all the stuff that ended up in the atmosphere turned the mornings and evenings into these vivid sunsets for the next 3 years. So that's where those colors came from. I think that's kind of an interesting thing. Any questions? You now have a hat to hang your studies on. Thank you very much. Today's lecture is on personality disorders. So I want to start it with a little thing from the Irish Mental Health Hotline.